My speaker's not on? Oh, shoot. Right.
Can you see me okay? Can you see me, Jamie? Hear me?
You guys can hear me?
Yeah.
Yep.
Awesome. Before we start admitting anyone, I'm just going to share the screen because then I lose everything. So if there are any questions in the chat, I may not be able to see with the thing shared.
Okay. Are you going to have Teams on a separate screen so I can ping you?
Yep. And you know what? Before I do anything here, let me just pull this chat out. I think I can create a separate window. Yeah, I've got that there. Okay. When I'm sharing, can you guys just see the slideshow?
Yes.
Excellent. Okay, my name's changed. Matt, your name has changed.
Yeah, I'm going to stop my video and audio.
Okay.
All right, see you guys.
Yeah. Let's admit in 1 minute, okay? Okay. I've got my chat up, so we're in good shape here. Can you guys see my video okay? Yeah. That I can't see it. Meeting room just keeps going up. Awesome. I can start admitting. Yeah. Just give it 1 moment here while everyone's jumping in. Great, let's begin. Hi, everyone. I'm Jamie from 3Terra. Welcome to our Innovation Center for Health Records Management. We would like to start by thanking all of our speakers as well as our attendees for their time. We know everyone is very busy, and we appreciate you all for being here. To be courteous to our speakers and avoid background noise, we have muted everyone's mics. We ask that only the speakers turn on their cameras and mics for their sessions. After each session, we will have a short Q&A period. So if you'd like to pop your questions or comments into the group chat throughout the session, we will monitor these and address them during the Q&A session. Please add any relevant notes, like who the question is for, to help with this. We will also be sharing the contact information for each of our speakers at the end of the event. By request from many that were unable to attend, you will have received a notice that the session is being recorded. In case you did not see it on the registration page on our website, we have now linked all past session recordings on this page, and we will add this one as well once ready and share it with all of you. Each time we host one of our Innovation Center sessions, we consider the themes that we hear about from all of you to ensure that the topics we discuss are relevant and helpful. Today, you will be learning from your peers, fellow managers in the health records domain, and their experiences around presenting their team's achievements to hospital leadership, how they monitor coding variability and performance, and you will also learn some exciting tips on where to even begin to advance your QBP review process. At the end of the session, we ask that you please complete the brief survey that will be provided to ensure that any topics that you would like to hear about are included in future innovation centers. To begin, Matt will introduce our first session with Sonia.
Good afternoon, everyone. My name is Matt Gertz from 3Terra. Great to see such a great turnout today. Really excited to share, the set of speakers that we have today and a kind of a wide variety of topics that we're going to talk about. A question that often comes up once hospitals have used DQA for a little while is that of themes. Specifically, what are the common data quality themes that are coming up so that we can tackle data quality proactively? And that might be through physician education, that might be coder training. And to that end, about a year ago, we introduced a set of reports into the tool called Coder Performance Reports. And the aim was to give hospitals visibility and insight into where there's variability amongst coders and where there's an opportunity to follow up and kind of understand where there's educational opportunities to get proactive. As a follow-up to this, we want to share experiences of one of the hospitals that's integrated this deeply into their processes. So I'm really excited to have speaking today Sonia Shields from Joe Brand Hospital. She's the Director of Health Information Services, and she's going to talk a bit about how they're using the DQA platform to identify and address coding variability amongst the team. So Sonia, if you don't mind jumping in and presenting on coder variability.
Thanks, Matt. I first want to start off and thank the 3Terra team for inviting me to come today and speak. I was asked to, can you see my presentation? My slide deck?
We can, yep.
You can? Okay, great. And I see a lot of familiar faces, so it's great to see those faces today. So when Matt and Jamie and the team reached out, they were asking if I could potentially speak about some experience I'd had with them in monitoring coding trends and variability. So I just want to thank them for the opportunity to share some of what we have gained from using 3Terra DQA with our coding team. So my highlight today is going to be speaking about the manager reports and some other considerations that we've used from DQA to partner with the strength of the manager reports to help us in our work. So I first want to start off with a little bit of history as a new adopter. So a few years ago, I was a manager at a coding manager at a teaching hospital where we had just adopted 3Terra. And as the coding manager, I was excited about 3Terra DQA, and I wanted to not only be able to create efficiencies in our coding workflows to improve data quality, but to see how I could, one, use 3Terra to assist me with performance management. And with some of my background in decision support, I also wanted to be able to look at trending of the data to assess my coding team's needs, and also additional data to better understand any themes at our organization with missing documentation. This is to look at and address the other side of data quality that we often feel is out of our hands. So that missing documentation piece was something I was really curious about. So I wanted to use 3Terra to help me identify areas of opportunity for both coder and physician education. So we had adopted and implemented and started using it, and I was struggling and spending a lot of time trying to manually guesstimate the pre and post value of each of the data quality checks that we would load to 3Terra, and to evaluate how each coder was working the data quality checks. In regards to the coders, I was asking myself questions like, who's struggling with these checks? Is everyone understanding them? Is everyone reviewing them? Is everyone understanding the checks? I was also looking to quantify the impact of missing documentation and how it is impacting potential loss of weighted cases. So it was at this time I was frustrated and spending so much time, I reached out to 3Terra for help. And I met with Matt and his team, and they were amazing. I put forward my suggestions for 2 separate reports, one for DAD and one for NACRS, with restricted visibility to only our coding leadership team to respect the privacy of our team.
Open it up.
Thanks, Viola. They went away and developed multiple manager reports and pushed them to all our clients. They had provided more than what I had asked for, more than just the 2. And they had created buckets to assist me in my drill down, metrics galore, and the ability for me to take snapshots of all of our pre and post data quality work at any interval I wished, daily, weekly, ad hoc, however, multiple times a day, however. This gave me so much more flexibility in my work and eliminated me from having to replicate multiple algorithms to reconcile and measure some of what I was trying to analyze. It was amazing, and it allowed me to do my job as a manager much more efficiently. So this is a snapshot of what we call the manager reports that should be limited at Matt's request in 3Terra. They will limit them to your leadership team, coding leadership team. So today I want to speak about 4 use suggestions for the manager reports. First one is to evaluate the growth of your data quality program. 2 would be to use them as performance management tools. And the trending visible in the reports provides the ability to take snapshots to assist leadership in better understanding where to target education for the coders and to quantify the impact of missing documentation to support in physician education sessions. So that was an interesting part that I'm growing more myself as we and the team grow. This is a snapshot, a picture of 3 years. So we've got 2021, 2022, and 2023. So this is data I was able to export very quickly from 3Terra, and I can do all sorts of things with it. But this is actually just for acute inpatient. So I'm focusing today on DAD and our acute inpatient, but there are the NACRS metrics also available. So this is looking at the percentage of cases with data quality checks against your discharges for that fiscal year. So in 2021, 22, 3% of our discharges had checks set against them through 3Terra. And in 2022, 23, it was grown to 9% of the discharges had data quality checks against them. And this year we're projecting to be 10.3% of our discharges will have checks against them. So at first, people may look at this and they may ask, well, does that mean your data is getting worse? And I looked at this and I thought, oh, this doesn't tell the picture I was really hoping it would tell. But so I was asking myself, is this a positive picture or a negative picture of your data quality program? So the truth is you really need some more data. So the data that you're able to pull out of the manager reports was able to show us that since the addition of some additional new value added checks to the data quality DQA and a new data quality team that we put in place, we're projecting to almost double the gain in weighted cases compared to 2 years ago. So the green bars on the right at the below, just for privacy for our organization, I didn't put any dollars down there or true weighted cases, but this actually is a true representation of what we're anticipating for this year. So from 2021-22, although we only had 3% of our discharges having checks against them, we've grown it to 10%, and our gain that we're able to get in weighted cases is going to be doubled as a result. So I would say that supports your data quality program and the work that your team is doing. Another key thought I want to share with everyone is the value that 3Terra gives you of taking the pre and post snapshots to give you more detail. So it's really important. You can take those snapshots, store them, save them, and then you can do a before and after snapshot of when you did education or when you implemented a new data quality check. You can see the gains there. So the performance management application allows for continued trending of your targeted education needs by team and or by coder, and any improvements that you may have seen in the team or by coder as a result of the education. So if you take a lot of the pre and post, you can actually see improvements over time, and you can also see which coders may be struggling with different checks. So you may have one of your team members, I'll put out a few examples. You may have one team member who's struggling and doesn't know where to really look for home care documentation, where the others are all fine. So you may want to do some focused education when you see that person has more checks for home care. The same for a new check like chemotherapy, and so on. And then over time, you can actually see improvements once you stabilize on those checks and see improvements. You can also look at the snapshots to see improvements in documentation over time. So as you go out and you talk to your physicians about, the importance of documenting your bedside flagged interventions or chemotherapy, you can track that over time too. This is another picture of 4 of our coders. I didn't put everyone in here, but it's just our acute inpatient sample of our coders. So the gray is 2021-22, the green is 22-23, and the blue is our current year, with including the red. So you can see by coder, these 4 coders, that in year 1, so the gray, they were very similar. There were fewer checks coming up for coder D here. In 2022-23, coder A had a few more than her colleagues. But in this year, current year, there is one coder that's almost double the number of checks in relation to her colleagues. So that tells me that coder may need more education, more supports, and then that allows me to go back and do a drill down and try to find out where are the challenges, and maybe send them for more education to Kai-Hi, or do more chart reviews with our new supervisor or data quality analyst. So it allows you to know where to start focusing education. This is just a sample, as I mentioned, focusing on one report today, but I would encourage everyone to really dig into the other manager reports. But there's the inpatient data quality review report that has all of these metrics. So in yellow on the left there, I've just highlighted the 2 that I love grabbing first is the % of reviewed cases by coder. And then you can compare that over time. And then the recovered HIG weight by coder. Once I have that, then I also like seeing, are the coders working? Are all the coders working the data quality checks? In my past, I have had a larger team and have seen some coders day after day. We've told them to start looking at home care, or we told them to look at certain buckets of data quality checks, and they're not looking at them. So that allowed me as a manager to follow up with that coder and say, you know what, get on there. We need you on there. We need you doing your checks. So I didn't have to run reports from an external database or anything to see that. So that review in blue, the reviewed checks, allowed that visibility at a glance really quickly. And then also you can see that the other one, change case count. I love to see right above the % in reviewed cases, you see reviewed case count and change case count. it's really interesting to see the difference between those. So of the ones they're reviewing, how many are they changing? It allows you to have more conversations with your coders. And then on the left there where it says buckets, these are the buckets that 3Terra created, and I think they're brilliant. It allows you to kind of see themes. Your outliers is one bucket. They have your general DQ checks, your discrepancy ones, which are another clue, cross-references near QBP by coders. So is there education needed with those? You know, does one coder have more checks in that bucket than others? And then there's the third bucket, outstanding cases for data quality review. The other inpatient report it's interesting is the inpatient quality report. And it has similar metrics, but I really like the first one there on the left. So some other considerations that we've found to pull in with the manager reports to help us support in conversations are the confidence we're able to say to our coding team, you know what, this is really restricted to our coding leadership team. Don't you worry, it's not going to be punitive. This is for us to encourage and support you where we need to support you. So I love that ability that 3Terra has allowed. It also, as I mentioned, gives you the ability to see who's using DQA and who's not for follow-up if needed. The ability to stagger data quality checks and to quickly evaluate related CMI recovery and value of checks. So the chemo home care, these are just some examples, DI for the NACRS data set. The ability for leadership to triage and prioritize data quality work according to multiple buckets. So if you find that you have a greater recovery with one data quality check and you're on a time crunch, you may say, you know what, we only have so much time left in the year or in the month, and we're going to push these ones out. And over time, the coders will learn from them and should improve. The DQA, the manager reports also, provides daily visibility of changes over time. So the ability, again, I can't emphasize more how I love taking the snapshots. I love the ability for the coders when there are multiple diagnoses listed in a discharge summary or in a chart, and when they're presented, which one might be a better fit. So the analysis tools that 3Terra has been a really good education tool for the coders. The QBB checks, I'm really excited about Lisa Landry's presentation coming up at the end of the session. I can't wait to hear more what will you do there. I would really encourage the coding teams to work with your decision support departments with the QBP checks, especially with the medical ones. You know, if you're over or under volumes, you really need to understand your volumes. But the QB check with the surgery placement of the principal procedure was an eye-opener for our team. So it was a great educational tool right off the bat. They're learning which procedure actually triggers a QBP. So that's a wonderful tool too. And overall, the manager reports, the DQA tool, it really improves the confidence in the coded data. So that's the end of my presentation. I will put it out to the group for questions. I do have a question for the group afterwards myself, but I'll leave it there.
That was awesome, Sonia. Thank you so much for sharing. So we're going to move over to the group chat. If you have any questions, please pop them in here. We will also be sharing contact information afterwards, and Sonia's been gracious enough to add her email here. So if there are any questions that you're not feeling comfortable talking about right now, but we're very open. Sonia, did you want to share your question with the group while we're waiting?
Sure. I ran this by Jamie and Matt beforehand, but so one of the analysis tools that the team and I really love here is the analysis tool that allows the ability to compare differences between different diagnosis scenarios and how it impacts groupers and adding comorbidities and so on, and the impact to HSMR and all of that. So what we're hoping for, and we'd love to hear what others think, and 3Terra wants to hear what you think too. Would others be interested in hearing of 3Terra adding in the interventions into that play scenario. And I know 3Terra wants to hear from you. Jamie, Matt want to hear from you. Would you find that useful or not?
Yeah, and I'll just jump in here and say it's something where we always like to hear feedback from people and where there is functionality that would be helpful. Like Sonia has brought forward. It's something where, if there's interest from the community, that's going to prioritize things within our development team. So I'd love to hear the feedback of the community and either now or as a follow-up afterwards as to whether interventions in those scenario tabs would be worthwhile.
3Terra has been amazing. They listened to us. That's where they started these manager reports, and so let them know what you guys think. Thanks so much, Jamie. Thanks, Matt.
Thank you. That was awesome. So we're going to move on to our next session here. So the title that we came up with for this is Communicating Data Quality Results to Leadership. So at the end of every fiscal year, 3Terra compiles an activity analysis tailored to your hospital. And we offer to present this directly to your leadership team. So in addition to showing key changes in inpatient and outpatient activity, this presentation serves as a platform to advocate for the data quality efforts of health records teams to your leadership. However, we understand that it can be difficult to secure the time and attention of senior leadership for these meetings. Today, we're joined by 3 managers, each of whom have been successful in engaging their leadership teams and communicating their team's achievements. Please welcome Shay Talley from Headwaters, Jeremy from CHIO, and Linnea from Michael Garren. If you can all please turn on your cameras and mics.
Hello, everyone.
Awesome.
Hello.
Hello.
Thank you. This is wonderful. So the way that we're going to run this session is each panelist will have the opportunity to answer each of the questions presented. We have 3 different questions, and then we're going to have a Q&A session to follow. So to be courteous, please hold your questions until the end or pop them in the chat throughout so then we can address them once we're ready. All right. Is everyone ready?
Yes, indeed.
Good. Wonderful. So our first question here, can you please provide a high-level overview of your experience in gathering the leadership audience for the year-end analysis session this past year? For this question, we're going to start with you, Shay Talley.
Hello, everyone. So thank you for this question and inviting us and having me on the panel. So about the leadership, gathering the leadership, Headwaters is very much driven by the data. We are moving as a data-driven organization. So when I shared this information with our leaders, they were very excited, especially our CFO. She was very excited to learn about the trendings and the data, whatever is shown in the presentation. And mainly the data was combined with the finance, the QBP pieces and all those. So that also excited the bigger group of the finance. So that's why we were also the presentation that helped looking at our master planning and making leaders their necessary decisions. So this presentation does interested and help the leaders attend this session.
Amazing. Thanks, Shay Talley. All right, next, Linnea, can you please share a high-level overview of your experience in gathering your leadership audience?
Sure. Thank you for having me on the panel, and thank you for the question. So myself, I'm Linnea. I've been in the Michael Garren Hospital for 18 years, and myself was a coder as well as now a manager for the health records. So for your question, we in our hospital, we decided to engage our key stakeholders and decision makers when it comes with the sharing our year-end results. And there are a couple of main reasons for us, especially we were a hospital that we were building a new hospital and we were moving into that hospital. So it was important for our the stakeholders to understand the trends within the QPP and how it impacts the PCOP funding, because there was a serious concern about the PCOP funding. And all of us know that for the past several years, due to pandemic, our surgical volumes, especially the QBP volumes, were down, and everybody was really concerned about how that is going to impact. So it was really important for us to engage them within this year-end analysis review and give them that confidence of what we are doing from a health records and coding perspective to help to improve the funding as well as the QBP volume and increase the case weight. So it was mostly they were really interested to be participate, and then we engaged the main key stakeholders impacted by the QBP and the decision makers from a funding perspective.
That's awesome, Linnea. Thank you so much. I'm sure a lot of our audience here can resonate with the PCOP and the importance of making sure you're capturing everything. So that's a great point. Jeremy, last but not least, can you please
Awesome.
provide a high-level overview of your experience?
Yeah, of course. I want to preface, because this plays into my answers a little bit, but this year was different than most for us. So we had the opening of a new unit that they're calling the intermediary care unit. And it affects a lot of the coding that we do and how we capture those specific cases. And there was also a lot of discussion about how we do things at CHIO specifically in the last year. So the data in itself also looked different. So it's a particularly important year for the organization and for us to share this data with leadership across the organization. So for us, one of the first things that we encountered was talking to different leaders who might not be as aware of what we do and the system, well, specifically even the system. Like when we talk about 3Terra, we had some shrugs at first, not knowing what that is, what do they do? So bringing people up to speed was one of the first things that we encountered when talking to different leadership, to help them quickly understand what the tool is, what we use it for, and why it's important to them now. And that's what we did as part of our strategy, or that's what we're doing. And an important element is considering the audience, right? Considering we had such an array of people and an array of leadership that wanted to be involved in this and an interest in what has changed this year and why it's important to look at this data has played significantly. So, tailoring our messaging is very important to that audience, because it is a different group that doesn't maybe even have the knowledge that we have naturally in this field. So yeah, that's what I would say is the experience. Thank you.
Awesome. Thank you so much. Our next question here, and Linnea, we're going to start with you. Who are the individuals that you included in the session and why?
So for us, we are a community teaching hospital, right? So we have most of the medical and surgical QBPs, not all of them as part of the funding methodology, but the VP of, as per our organization structure, the VP of the clinical programs, most of the medical and surgical QBP falls under him. So we wanted to make sure not to have a larger group, because last year was the first time we were using the tool, and we want to have that to go to the right members. So we engaged just him, the VP of the clinical program. Then we had the VP of finance and the CFO. So they get the funding letters, they understand the funding formulas and expected volume, all of that. So they have really interest in to understand how this tool will be valuable. And we had them. Also we had our decision support team. So decision support team usually runs the data from the coding, and they are the one who usually presents that QBP volume and the cases. So we also wanted to validate the results are accurate and it's a reliable tool. As I mentioned, last year was the first time we used it. So we had our decision support team. Then we also engaged our CIO, Chief Information Officer. So health records reports to the CIO and myself. So we want to show her, demonstrate the value of the tool that we are using, and also receive the continuous support for continuing to use this tool, because they were already aware of the efforts put by health records team, the coding team, to make sure the QBP volumes are all accounted for, and all the accuracy is there. So these were the it's a small group, but we find that it is the most relevant group based on our organization structure that we wanted to engage.
Amazing. Thank you so much. Jeremy, we're going to jump back to you. Who do you include in these types of meetings?
Yeah, of course. So naturally, the sort of HIM leadership structure is always involved because it's very meaningful to the team here. But again, speaking to this year being different, there's a lot of interest from other groups and other leaders in the organization that wouldn't typically be exposed to this data. And so an example would be, like I said, the IMCU, so the leadership for all of our intensive care units, so any acute care area will, have an interest in seeing what's different this year, what the impacts of some of the decisions that we made operationally, and what that means. So the HIM group, of course, decision support also is always involved. We have them separate here, sorry, at CHIO, if that makes a difference. But yeah, and going up, so from the executive level and down, the structure, anyone within those teams we want to involve. Like we have the director, who does our surgical units, they're involved, all of our ICU units, of course. We get all of them. And it really helps bring a mixed bag of experiences and of knowledge to the table so that when it's time to look at the data, everyone dissects it in a bit of a different way. So, we might see certain trends and we might see data in a different way because we can see trends. We look at it from a pretty high level perspective, but giving the opportunity to these others leaders to view it as well from the tools that we have, like the 3Terra, is very interesting for them to get that opportunity to review it and contribute to the discussions from something that they wouldn't typically see in their day-to-day.
That's awesome. Thank you so much. And finally, Shaytali, who were the individuals that you included in the session and why?
Sorry. So the most, I think, whatever they said, I align with that. So for the leadership, I included the clinical directors, and along with them, we have the senior leadership team also on the table. We have our CFO and CNE. They were part of the presentation, and along with that, the finance director and the finance team with the decision support team were the part of the presentation. So decision support team, they liked a lot about the presentation because that gave them the insight of seeing the data with a different perspective apart from their own what they do on the regular basis. And same goes with the finance and financial consultants. They also find it very helpful being the part of the presentation.
Amazing. Thank you so much. All right. Our third question, Jeremy, we're going to start with you. In your experience, what are the keys to communicating this information to leadership?
Yeah, so I think each organization is a little bit different in this regards. It's important to speak the same language. So at CHIO, we have lean culture. We use lean methodologies a lot in the work that we do. So using those buzzwords, using those terms that everyone in the organization is familiar with, creates a much more effective communication strategy so that when you are crossing over from one team to another, there's been a lot of discussion about finance, about, the executive team, ORs, acute care areas, and involvement from leaders who, like we said, don't typically see it. So using the language that they can relate to so that we can convey the message effectively, I think is very important. And when creating, the presentation that is being put together for those leaders, it's really important to tailor the information to the audience. Our acute care leadership is going to care about different information than our finance team will. So I know the discussion that we had this year was segmenting our presentation into different parts so that anyone who's acute care can show up for the first portion of the presentation so they can see the information relevant to them. And then afterwards, it would be a different segment, and then we'd have the leadership that is applicable to, et cetera. Just so we're making effective use of their time, and we ensure that for the time they are there, everything is relevant to them. So that way we keep them, well, they're a captive audience, I should say. Right. That would be that's my experience. Thank you.
That's awesome. Thank you so much. Shaytali, I'll ask you to go next. What were your keys that you used when communicating this information?
So the keys were we presented with having the high level bullets, stating the complexity, the QBPs, and the volume trends, and which definitely help a lot to the audience to just have a snapshot of what the presentation is, what the presentation includes, and what are the main key takeaways of the presentation. And along with that, to use a simple language, which may the other people who are not very who doesn't align to the day-to-day work with with our terminology can also relate to the presentation. They also can understand, okay, what does we mean by the HIG and the more complexity and lower complexity. There's also the typical cases, atypical cases, and all those bifurcation. So having the simple language definitely helps to the more clinical people to understand the presentation.
Amazing. Thank you so much. Those are some great points. Last but not least, Linnea, what was your key to communicating this information?
So it's almost the same like Jeremy and Shaitali was mentioning. We used a simple language, but we also make sure to include the terminologies or the language that is more familiar within our organization. So typical, atypical, and maybe because of the audience, the group of leadership that we selected, they don't go into the details of typical versus atypical, but they know QBP, the volume, case weights. Those are very common terminologies being used in our hospital. So we kind of used simple, very high level presentations when we were doing it. But what I find it interesting was when we presented to them, especially on the case weight, and we pull an example like these are the number of cases that we missed to capture the home care, and then we added it. It helped to improve the case weight. It actually facilitated a discussion among that small group in how can we improve it, and they being the champion to present that back to the MAC and letting the physicians know that documentation need to be improved because coders are having the challenge and this is the case weight. So that's what I find it helpful from our perspective. Use the simple, most familiar language being used among within the organization, but also give the key level and then the high level decisions about if they really want to get more, they understand more of the terminologies and the breakdowns. So they do have access to our reports and they can actually drill it down if required. But for the leadership perspective, we kept it in a very simple and high level, same like the others.
Amazing. Thank you so much. This is so great. You also have such wonderful experiences to share. We're going to move on to our Q&A. So if anyone has any questions, please pop them in the chat. As we're waiting, I have a question. And I'm just going to send it out to all of you. So whoever wants to answer, I'm not going to go through each of you this time, but it's an optional question. Was there anything that gave you pause in sharing this analysis with your senior team?
I'm happy to jump in if my panelists are okay with it. Yeah, and I think it's a great question, I think, in our field, right? We see a lot of data and sometimes, it can make us a little worried. There's data that, we uncover sometimes that we get a little anxious about. But the perspective that I always try and adopt is, the data is the data. It's there for a reason, and it's actually representative of something that is happening. So if I am bringing it forward to my leadership group, I'm doing it for a reason. I feel that it's relevant to that person for a specific reason. And let's dig into it, right? I want to look into it a little bit more. And it can create opportunities for improvements, or perhaps we uncover a risk that we didn't know that we were exposed to, as an example, when it's not as positive, perhaps. But it always creates chances for us to open dialogue around what the trends are that we are seeing. And also, in my experience, over time, it actually helps build trust with the leadership that you have and the people that are reviewing the data. Because if they see your willingness to bring it forward, for better or for worse, it's going to allow for future collaboration and having more open dialogue between the different leadership teams within the organization so that we can all kind of operate a little bit better, I guess.
Great. Thank you so much. Linnea, Shaitali, would you like to add anything?
For perspective, like as I mentioned, like this time we opened a new hospital, so timing was a challenge for us to share the results with the leadership. Especially everyone was very stretched within their responsibilities, and we were in the post-move analysis phase. All our inpatient, all outpatient, and part of the surgical programs, they moved into the new building. So it was February. It was around the February time, so it was difficult for all of us to get together and do review the results. But what I find was that I sent like just as a quick email to them to let them know this was the results, and I noticed a lot of interest from the leadership team. So we were not able to meet with them soon after the year end was closed, but later in the year we did met with them, and I find that they were really interested to continue to have that discussion with them and at least share a couple of times in a year with the results, which are really helpful for us. So they understand the trend, they understand the gap, and they also understand the opportunity for the improvement and providing that support for us. That was helpful. So timing was the biggest challenge, I will say, for us in sharing the results. Otherwise, there was really interest, so we didn't have a big challenge from that perspective.
Amazing.
I will just add on to whatever they have said is about to have, especially yes, about the timing. So now like we are definitely having a discussion to have this kind of presentation quarterly, not after the first quarter, but at least after the second, third quarter, just to have understanding where are we at and what can we do more so that nothing gets piled up for the end and no, like everybody can give more time and their insight on feedback on the presentation, because right now, yes, it's a year end and all, compiling the data and everybody is busy. So definitely we do want to have this presentation see like quarterly basis after second and third quarter, especially.
Amazing. Thank you so much, Jayjay. Thank you all for joining our panel today. This was great. You all have such different experiences. And once again, we will share everyone's contact information at the end if anyone would like to reach out to you directly. So thank you for allowing us to share all of that. And thank you for joining. Before we move away from this session here, I'm just going to invite Matt back. He just wants to add a little 3Terra update before we move on to our next session.
Yeah, absolutely. And thanks, Linnea and Chitali and Jeremy. As a kind of a quick follow along to this, we provide this analysis to every client hospital on an annual basis. And there's really a couple things that we learned about it, and I think things that we can improve upon. And the two things that I can think of is one, it's a lot of information. So I think Jeremy talked about it a little bit. We have to segment this. If it's QBP analysis, that really should go to a financial audience, and for the clinical analysis, there's a different audience for that. And there's a need to kind of segment all the information that we provide. And the other is one that Chitali kind of talked about at the end there, where it would be nice if it was provided on a more timely basis. Annually is great as kind of a year in review, but it's not timely enough to kind of keep at the top of mind on an ongoing basis. So going forward, we're actually re-envisioning this analysis. Instead of only making it available to hospitals once annually, it's going to be provided on an ongoing basis going forward and in a segmented fashion. So we're going to also be releasing the analysis as a set of interactive pages where you can go in at any point in time and see how things are going year to date or how things changed over the past month. Things like how are different patient cohorts changing, how are our conservable days changing, how is our activity and complexity at the hospital changing over the past short duration as opposed to the full year. This is something we're really excited about. We've been working on for quite some time, and we're looking forward to sharing details of this come June. So Linnea talked about it a little bit. One of the areas of emphasis that we always get asked about is quality-based procedures. And so part of this is going to be an interactive QBP analysis tool that we're going to include in the analysis as well. QBPs have been of particular interest over the past few years for a couple of reasons. One, through COVID, everyone's volumes were down. And now with funding mechanisms getting turned back on in full in 24-25, it's kind of been a point of emphasis. The DQA platform has included QBP near-miss rules for a number of years. Traditionally, Inpatient QBPs have been covered for many, many years now. And then a couple of years back, we included coverage for outpatient QBPs as well. This past year, we also introduced 2 reports that will help you understand the ongoing impact of the data quality work that you're doing. So this is something that a lot of you reached out to us about and said, hey, we'd love to know how many QBPs have I found and what's the impact of that and what types of QBPs have I found? This past quarter, we introduced 2 reports, one that shows you QBPs that you have recovered and are net new to the hospital, and another the transition report that shows you QBPs that have switched between one QBP to another after review was done. If you haven't checked it out yet, please take a look. Hopefully it's something that could be helpful for you, and certainly something that we've got a lot of requests about over the past little while. So one hospital that's been using DQA for QBPs for the past number of years now is Royal Victoria Hospital in Barrie. Over the years, the RVH team has developed a refined process that's enabled them to effectively review QBP cases, ensure that data quality is sound. So I'm really happy to introduce this morning Lisa Landry-Kwawu, who's the manager of coding and abstracting at RVH. And Lisa's going to share with us some of the process that they use and some of the lessons that have been learned along the way. So please, Lisa, go ahead. No worries.
Sorry,
Lisa.
can you hear
She's
me,
just having
Matt?
some video trouble. We can hear you now, Lisa.
Okay,
Yes.
you can hear me. That's good. You
We
can't
can.
see me, so we'll deal with that. Sorry, technical
would-
issues on my side, I think. So
No
apologize
worries.
for no video feed. I will share my screen.
Cool.
Always technical issues.
Of
So
course.
can everyone see my screen?
Not yet.
Not yet.
And I can share your deck if you'd prefer, Lisa, as well.
Sure, if you want to do. Oh, do I just have to click share? Maybe.
Oh, here it comes.
Okay.
Oh, now. Perfect.
You can see it, correct?
We can.
Okay, perfect. I will continue, hopefully with no more hangups. So thanks to Matt and Jamie and the rest of the team at 3Terra for the invite to present today. We've been working, as Matt said, with 3Terra for a number of years, and it seems there's always something new that we're learning or improving on. So definitely a great tool and highly recommend the partnership for sure. So for RVH, we started our QBP review process actually quite a while ago, before we even had 3Terra as an instrument to use. But we began with just a review of the actual the handbooks that are available, whether it's through Ontario Health or CCO or whoever has the specific QBP that you're interested in. Reading through that, finding the coding specific details. And from that review, we were able to create some QBP tip sheets. We call them tips for docs for physicians, but our team utilized them and other areas throughout the organization as well. I will show one in one of the coming up slides, but I just thought I'd review kind of our process first. So we created the tip sheets, and then through the creation of those, we educated our coding team, we educated physicians and other professional staff throughout the organization on what specifically from a coding perspective is important for capturing the QBPs to ensure that we're garnering the funding for our institution. So we coordinated a lot with decision support. And also at RVH, we have financial planning and analysis team. I think other organizations refer to them as financial consultants, but they're really the ones who look at the big picture budget-wise across the organization. So, you know, whether from actualized earnings from QBPs and cases, or even from a planning perspective for surgeries. And with them, we also keep track of where we're at as far as our volumes. You know, are we over acting in one area and maybe have under volume in another area for the QBPs if they're, you know, somewhat close. So just keeping an eye over that. And there are some tools that have been created through our decision support that at a high level we can go in and see volumes for all of those QBPs. And the other piece that we, worked in partnership with decision support and financial planning on was the development of a document that would really help our team and other areas understand, you know, our volumes for QBPs, you know, what we're allotted, how we're performing, and as well what the projected financial impact from a particular QBP would be. And we've also equivalized that into a weight. So, you know, looking at a HIG weight, does it make sense to move something into a QBP, or because it might be already at a higher HIG value, does it make sense to not move it into a QBP? But, you know, from a coding perspective, we really would have no way of knowing the value of moving it or not moving it without that understanding of kind of a weight equivalent for our QBPs. And I will show that document as well as we move through. So this is our tips for a doc sheet that I referred to. This is one that we prepared that was very specific to breast surgery. And, you know, within that, we've, what are the inclusions in that QBP? You know, not all cases are data and knackers. This particular one was. You know, what is the admit category and entry code for the patient, because they all do not apply to QBP. So just understanding that is helpful as well. If you've got transfers in coming from smaller organizations, good to know that kind of information. Are there any specific exclusions? For this one, it's obviously just an abandoned, canceled. So just having some very specific information, and we kind of keep the same information across all of the tip sheets that we create as well. And related to this specific breast surgery one, you know, things that we've always asked for the physicians to provide for us: the location of a cancer, if it's a cancerous, you know, what was the specific intervention that was performed, a lumpectomy, a mastectomy, were there flaps involved, and what kind of flap was it? You know, were there any devices that were implanted at the time, sentinel lymph node biopsies, node dissections, you know, all of that information. So anything that's relevant to coding that can, you know, move a QBP into a different bucket, or, you know, cause it to have a higher HIG volume, you know, very specific things that are important from a coding perspective. We also, for the coding team, captured a lot of the appendices that were available from the handbooks. So this is just some snapshots out of the specific breast QBP that we were looking at. You know, it's quite an extensive document, so I just did a few little shots. But this one is grouped into various different groups. So group one, you know, will have a table of diagnoses that apply to that. And along with the group one, you'll also have a list of procedures that would group to that specific area. So this can help you ensure that, you know, you're picking the right kind of codes for grouping your QBP, and to what level you're going to be grouping it at. You know, for more extensive procedures, you know, you might be in a group 4. So just, you know, having that understanding from the coding team is important. So we've managed to compile quite a number of these. And this is the document that I mentioned that we created along with financial planning and decision support. So the bottom portion, I just kind of took a closer in screenshot of it. Of course, the funding volumes are specifically related to our VH, so I did have to gray this information out, but it kind of just gives you an idea with the columns, what kind of information we are looking at within this. So, we do have a funding rate that we project a QBP would equal to. And then we also have the last column, which is the weight offset. So this is looking at, it would equate to a specific HIG for that funding volume. So if we have a case that is a higher HIG weight, and we have the possibility to move it to a QBP or, keep it outside of a QBP if it's not grouping there, we would also have that as, kind of to help guide us as we make those decisions. So without this document, I would say that, you're really going into a QBP review blindly because you don't know from a funding perspective what makes more sense. And this is really important information to have, before you can make those changes within the program. So very, very important tool for the team to use. So I just wanted to show a sample case from 3Terra that we might have looked at. So, an interesting one, breast surgery related, so fits right in. This one is flagging for a couple reasons. One, it's not grouping to a QBP because this column in the center is blank. If it was grouping, you would see something within that. And so the data quality checks related to this particular case is it's breast surgery with delayed reconstruction as a near miss, and it has the qualifying diagnosis for that in position 2 currently. It's also flagging because it's breast surgery with immediate reconstruction, and it is the qualifying intervention is present at position 2. So, going into this case a little bit further, this is what it would look like in 3Terra if we were to bring it up. So, I can see that, I've got a prophylactic removal of a breast and follow-up care involving plastic surgery of a breast. So looking at the interventions, they really are kind of cross-matched to each other. So my most responsible diagnosis actually more so matches up with my procedure at position 2 because this is a reconstruction procedure. My follow-up care involving plastic surgery of the breast matches more so with position 1. So what makes more sense, to move my diagnoses or to move my procedure codes? So I can refer back to the information I have from decision support and financial planning, and I can see breast surgery with an immediate reconstruction is a higher HIG value than a delayed reconstruction for this particular case. So, when I do make changes, of course, I'm going to review the documentation and the chart as well to make sure that, does that make sense to make those changes? And I did, move my follow-up care involving plastic surgery to the breast to be my most responsible diagnoses for this case. So just with the rules that came up through the review in 3Terra, I've marked the one invalid that I, didn't action, and I've marked the other one as valid to say, this is the one that is true. I would need to mark one of these as being valid, having made the change, if I want to be able to see the impact of this change on my case review, to see the total number of HIGs I may have recaptured over the year with my inpatient coding. So very important that the coding team knows how to mark their rules as they pop up as well. So just some items to be really mindful of as you're, reviewing your QBPs and your, where you may have a near miss or, you have the possibility of realigning to one QBP or another. The documentation is still key. We really have to follow what is has been documented by the physicians for the case. Does it make sense to change that QBP? Or, if we've had a really sick patient or somebody that just has not followed, a kind of a normal course of care in the hospital, and there's been other things that have happened, it might make sense not to group within a QBP. But again, it's looking at the chart and, making those decisions. You can't be doing it just purely, to see volumes for your QBPs rising or, to realize some QBP funding dollars. It may make sense to just leave it as it is. So if your documentation you're finding doesn't really align, but based on your review, you think there could be a change made or something just doesn't seem to be documented correctly, we often feel that physicians really don't know how to pick a most responsible diagnosis or to document the principal procedure well, because it's not really part of what they're trained to do. So in some instances, we've sent coding queries back to physicians to say, I think there's relevance in this change. So, they can agree or, maybe don't agree with the change, which is completely fine. So just, if they've documented their agreement, are you scanning that document, to keep as part of that record? So you have some validity for the change that you've made, or, is there somewhere that you're storing that information? Or, conversely, does the physician go in and make some changes to a note and do an addendum or something like that? So just making sure that that documentation is there to support what you've done. The other piece is working really closely with decision support, finance, financial planning and analysis, or your financial consultants, whatever it is you call your group, and also the surgical program, because they often will have, projections of cases that they will have. So, are we not seeing those after coding has been completed? Is there a reason? So, is the surgeon booking something that they would have expected to be a QBP case, but it didn't for whatever reason? So why are our volumes off? Or, is a physician booking something inappropriately as a QBP when realistically it would not or should not have been? So it's, again, education. So, whether you're educating your physicians or, your professional staff, and even your coding team, just about making choices along the way. So yeah, that's the process that we've taken at RVH. I think we've probably been doing a really thorough analysis of our QBPs for the last 3 years, I think, because, as I mentioned, without the tool that we've had provided from decision support and finance, we're really just blindly going in and looking at QBPs because you don't really know what bucket it makes more sense to group something to when it's available to you. So just having that understanding and that knowledge sharing with your groups at your hospital is really important. And that's it. So hopefully I didn't lose anybody along the way, but I'm happy to answer any questions or, contact me with any questions outside of this that you may have, and happy to do some knowledge sharing.
That was awesome, Lisa. Thank you so much. There were a lot of great tips in here. We hear these similar questions from all of you quite often. Are there any questions in the chat that we can help to address right now? All right. Thank you so much, Lisa. We really appreciate your expertise and sharing all of your tips with us. I'm sure you'll get quite a few emails after this session.
Great. Thanks, Jamie. Thanks, Matt. Appreciated the opportunity.
We're happy to have you. Amazing. So I appreciate that we're past 1 o'clock, but of course, all of these topics have been so interesting. We've learned so much today. I just want to thank everyone for your attendance, for your participation. We hope you found all of these topics valuable. To all of our wonderful speakers, thank you so much for sharing your experiences with the group. We really couldn't put on these events without you. All of the speakers' contact information is available here. If you miss it and you'd like anyone's email, they've all given us permission, so please feel free to reach out to any of us as well. And then finally, just to ensure that future sessions continue to improve, we ask that you complete the brief survey available here through a QR code or through the link in the chat. All responses are anonymous, but your responses really do help us create future sessions and ensure that the topics we discuss are important to all of you. So I'll leave this up here for a second, but thank you so much, everyone, for joining us today. Have a wonderful afternoon.